Welcome to this medicine masterclass on Cor Pulmonale. Cor Pulmonale is right heart failure caused by chronic pulmonary arterial hypertension. This occurs in conditions with chronic hypoxemia, which causes chronic hypoxic pulmonary vasoconstriction leading to pulmonary hypertension. The symptoms include dyspnea, fatigue, and even syncope. Cardiac failure symptoms such as fatigability, decreased exercise tolerance, weakness, and leg edema may also be present. Let's take a case-based approach. Mrs. Williams presents with chronic dyspnea. You believe she has cor pulmonale. What signs would you expect? On inspection, the precordium may appear hyperinflated, evidenced by a reduced cricosternal distance and increased anteroposterior expansion of the chest on inspiration. So this would be suggesting that you believe the cor pulmonale is as a result of COPD, for example. Therefore, on palpation, the apex beat would be impalpable and a right ventricular heave may be present due to right atrial and ventricular enlargement caused by the pressure on the right-hand side of the heart. On auscultation, sounds 1 and 2 would be present. Now remember, S2 is split into an aortic and pulmonary component. The aortic component is loud in systemic hypertension and the pulmonary component is loud in pulmonary hypertension. So you would expect in cor pulmonale P2 to be loud. No additional heart sounds were auscultated. You may hear a murmur. An early diastolic murmur called a Graham-Steel murmur would be present in the pulmonary area, and this is suggestive of pulmonary regurgitation, and that's because the pressures are so high in the lung that they're forcing back pressure and a subsequent regurgitation through the pulmonary valve. Advanced disease would also result in tricuspid regurgitation, and the murmur of tricuspid regurgitation is a pansystolic murmur, just like mitral regurgitation, except this is heard at the left sternal edge. So the Graham-Steel murmur is the murmur associated with pulmonary regurgitation. It's a high-pitched early diastolic murmur, best heard at Erb's point. That's the second intercostal space at the left sternal edge in the pulmonary area. And it occurs due to high velocity flow back from the pulmonary valve secondary to pulmonary hypertension. The tricuspid regurgitation is the murmur associated with more advanced pulmonary hypertension, and you'd see advanced signs of right heart failure, so peripheral edema and ascites, and you'd hear a pansystolic murmur, a low-frequency pansystolic murmur heard over the lower left sternal border over the tricuspid valve. And this murmur would be accentuated, well, both of these are right-sided murmurs, and so they would be accentuated in inspiration and decreased in expiration, and this is known as Carvalho sign. And there'd be an associated rise in the JVP with giant CV waves. Remember, the V waves are representative of atrial filling, and anything that would increase the filling of the atria, so for example, a regurgitant jet from the ventricle through the tricuspid into the atria would cause a giant V wave. And you may also have a palpable pulsatile liver on examination. Other supporting evidence suggestive of cor pulmonale, you'd expect a regular pulse, although it may be bounding as a result of chronic CO2 retention. No radioradial or radiofemoral delay would be expected. The patient may have central cyanosis, an elevated JVP with prominent A waves and V waves, and the patient may have peripheral edema with pitting edema to the midshins. Differentials include cor pulmonale with features of both pulmonary regurgitation evidenced by an early diastolic murmur and tricuspid regurgitation evidenced by a pansystolic murmur, and a result of both systolic and diastolic murmurs being present. Differentials are wide for other valvulopathies, including the murmurs of aortic stenosis, mitral regurgitation, and stenosis. However, these murmurs would have a different characteristic and could be readily discerned on echocardiography. So putting all of this together, to present the case, we would say Mr. or Mrs. Williams presents with chronic dyspnea. The patient was comfortable at rest, and I believe the patient has signs consistent with cor pulmonale. On inspection of the precordium, which appeared hyperinflated, as evidenced by a decreased cricosternal distance and an increased anteroposterior expansion of the chest, I also noted the apex beat was impalpable, and I noted a right ventricular heave. On auscultation, heart sounds 1 and 2 were present, and remember, sound 2 is split into A2 and P2, the aortic and pulmonary component, and A2 is loud in systemic hypertension and P2 is loud in pulmonary hypertension. So you would say that P2 was loud and no additional heart sounds were present. I also auscultated an early diastolic Graham Steel murmur in the pulmonary area and a pansystolic murmur of tricuspid regurgitation. These features are associated with advanced pulmonary hypertension. The signs consistent with right heart failure may be noted, such as peripheral edema to the midshins and low volume ascites, and the presence of a raised JVP with prominent A waves and giant V waves. The pulse was regular, bounding in nature, and the patient had evidence of central cyanosis, and these features are consistent with Cor Pulmonale. Let's go on now to discuss this in some detail. So the causes are those which result in chronic hypoxemia, COPD, chronic asthma, fibrotic lung disease, obesity in which there's mechanical hypoventilation, muscle weakness, kyphoscoliosis in which there's reduced lung volume, high altitudes, vasculitides, chronic PEs, chronic pulmonary hypertension can all result in Cor Pulmonale. So to investigate, a whole series of investigations are required to help pinpoint the etiology. Bloods could help determine whether there's an anemia. The hematocrit can help determine the degree of anemia. Usinase, LFTs, thyroid function tests, clotting, glucose, cultures if there's signs of infection, and importantly a blood gas, an arterial blood gas, can help determine the pH, the PO2, the PCO2 and the lactate and the bicarbonate, which can give an overall clinical picture of how well or unwell the patient is. If the patient has any sputum, that should be cultured, and if there's any pleural fluid, that should also be analysed. A radiograph and CT chest is important to help determine etiology, and the patient should undergo pulmonary function tests and bronchoscopy, as well as echocardiography to determine the degree of cardiac dysfunction. And all of these investigations should be seen in the context of previous investigations to monitor disease progression and regression. To manage these patients, a holistic patient-centered approach should be employed with the involvement of a multidisciplinary team. Conservative medical, interventional and surgical options should be used. The underlying cause has to be addressed. So whether that's COPD requiring smoking cessation and pulmonary rehabilitation, whether that's cystic fibrosis requiring regular treatment of complications, whether that's fibrosis requiring opiates and potentially steroids, the underlying cause needs to be addressed. The respiratory failure, if the PO2 is less than 8, the patient may require long-term oxygen therapy. When cardiac failure manifests, that would require treatment, particularly with diuretics, potentially ACE inhibitors and beta blockers. And if the hematocrit is elevated, the patient may require venesection. And in younger patients, or in patients where a multidisciplinary team deems important, a heart-lung transplant may be required. Thank you for attending this medicine masterclass.